John Todd from the section of infectious diseases, and I'll be talking this morning about Aspergillus and Mucor. These are scary infections. We don't see them that often, but they can be very damaging very quickly, and we need to be aware of them and ready to treat them quickly when they occur. Let's see. There. Okay, they both live as hyphoforms, as molds, not yeasts, and both of them produce spores. Okay, they can they can cause invasive infection, and they can invade blood vessels, and by invading blood vessels, they can infarct tissues. Having infarcted tissues, they can spread then from the dead tissues to the healthy tissues and be quite destructive very quickly. They can cause death or permanent damage this way. So we need fast diagnosis and fast, effective treatment. Aspergillus and Mucor are common in nature. Main reservoir is decaying plants, decaying vegetation. They also found in the soil. They're pathogens by accident, quite unlike real professional pathogens like tuberculosis and cholera, where the disease they cause is important for their survival and spread. With tuberculosis, forming a cavity in the lung is important. The lung is a very aerobic place to start with. You form a cavity, it's even more aerobic, plus the cavity communicates with the airways so that you can cough the bugs out and that those bacilli can go infect someone else. With cholera, the massive diarrhea tends to spread the organism around the environment and get it into the water supply. These organisms gain absolutely nothing by causing an infection, and it's pure accident, and the humans are just a complete dead-end host. They live on decaying plant matter. These infections are not contagious from person to person. Okay, both of these can rarely invade a normal host. So you can't say, oh, it's a normal host, not immunocompromised, we don't have to worry about these organisms. You always have to worry about these organisms. However, they usually invade compromised hosts, and neutrophils are important for defense. Okay, immunocompromised, particularly hematologic malignancies, and among the hematologic malignancies, particularly acute myelogenous leukemia, and also allogeneic stem cell transplants. These are the two groups that are most likely to become infected with Aspergillus and Mucor. And especially with neutropenia with less than 500 absolute granulocyte count. Neutrophils are important for these two organisms. Also, prolonged high-dose steroids, especially in the treatment of graft versus host disease. And with immunocompromised, they are both a problem, but Aspergillus is more of a problem than Mucor. Okay, both of these usually enter through the respiratory tract by breathing in the spores. In there, they can either colonize or infect. These can be colonizers. And the infection can range from mild to rapidly fatal. Okay. With pulmonary infection, they lodge in the lung, and then they can spread through the lung and to distant sites, especially the brain. Lung involvement is more common with Aspergillus than with Mucor, but both of them can invade the lung. Suspect lung infection with these organisms with fever, cough, chest pain, short of breath, and hemoptysis. That's coughing up blood, of course. Okay, rhinocerebral, here breathe it in and it lodges in the nose or the sinuses, and then they can spread from there out to the face, spread to the orbit, and involve the tissues around the eye. They can spread directly to the brain and can spread to other distant areas of the body. So Aspergillus and Mucor can get to the brain as a distant metastasis or can get to the brain from rhinocerebral infection by direct extension. Rhinocerebral is more common with diabetic ketoacidosis than with neutropenia. But either of these organisms can happen in either of these sites with either of these types of compromise. Okay, suspect rhinocerebral infection with fever, nose congestion, purulent nose discharge, sinus pain, headache, and more advanced with face swelling, decreased vision, and diplopia, and also if you can see obvious necrosis, that is, dark brown or black areas in the face or in the nose or inside the mouth. And if you find these, you want to get the surgeons to consult with you immediately and consider biopsying any areas that look as though they may be involved. Okay, on the history, you want to get any history of immunocompromise, particularly the key groups of acute myelogenous leukemia, especially if they had recent chemotherapy or stem cell transplant. Anybody can get these, but those groups are much more likely. Also, does the patient have diabetes, and is the patient currently poorly controlled acidotic? The history of fever, cough, chest pain, dyspnea, nose symptoms, face pain, eye symptoms, particularly diplopia, and speed of onset. These are all important in thinking about, are these organisms likely to be involved, and how serious a case are you dealing with? Okay, on the physical exam, you want to check out the nose, the eyes, the face, and the mouth. And if you find evidence of infection, consult the surgeons for their evaluation and for biopsies. The lungs, you listen to the breath sounds. Are they decreased, and do you hear growls? Chest x-ray, chest CT, and sinus CT can be quite important. If you're thinking of the lung, of course, a chest x-ray and a chest CT, the x-ray is relatively insensitive, and sinus CT is crucial if you're thinking about rhinocerebral. Okay, fungal smears and cultures of sputum, bronchoalveolar lavage can be very important. Remember, these can be colonizers. Just because they're there doesn't mean that they are causing a problem. You need to put the whole case together. What was their predisposition to these infections in the first place? What are their symptoms? What's the physical exam showing? What are the imaging showing? And put that together with any sputum and BAL findings. So you want to do both smear and culture. Okay, skin infection, usually in either burns or severe trauma, especially if there's soil contamination. This is more likely with Mucor than with Aspergillus, but both can do it. And saw a good bit of Mucor skin and soft tissue infections with Hurricane Katrina. This was a lot of people were bounced around and had trauma with the muddy water, and also with the Japanese tsunami, similar situation. So if you've got necrotic skin lesion in someone who's had trauma, particularly if it was contaminated with soil or dirty water, and you find Aspergillus or Mucor, think carefully about it. It may indeed be the problem. Okay, I'll limit talk about taxonomy. We could go on the entire time about all the disputes and how these fungi should be classified. I don't think that's what you're here for. Won't talk about allergic bronchopulmonary aspergillosis. That's a completely different subject. Won't talk about fungus balls. I've said all I'll say about cutaneous infections with Aspergillus and Mucor. and I won't talk about unusual sites of infection. Among the Aspergillus species, the important ones for causing infection, mainly Aspergillus fumigatus, but also Flavus, Terrius, and Niger. Okay, here's Aspergillus. It was first described in the 1700s. The sporangium reminded the scientist who was looking at it of the, I'm glad we've got our father here, of the aspergillum, which the priests used to sprinkle holy water. So he named the fungus Aspergillus. Okay, here's how it appears in culture and in tissue. You have frequent septa, which are quite easily seen, and tends to have acute angle branching. Here you've got acute angle, acute angle. Okay, here's Aspergillus in the lung. See in the center an area of necrosis and around it an area of hemorrhage. And as we will see on the X-ray, this will show up as a dense center and a ground glass halo surrounding it. And we have that hemorrhage and infarction because of the blood vessel invasion. Now here's the halo sign. There's the dense center and the ground glass halo around it. And here's in later Aspergillus what they call the air crescent sign, in which you've got the dense center is the necrotic area is contracting and leaving an area open to the airways, which is now filling with air. So the air crescent sign of later Aspergillus infection. Okay, here's another. This was a 10-year-old boy with hematologic deficiency. He had here the halo sign, the dense center, and the halo around it. Here he'd been treated, and you've got the center is contracted, leaving an area of air around it, and here a year later it's healing up and contracting. Okay, here's another air crescent on the chest X-ray, air crescent on the CT, and here you can see the hollowed out area when they resected that infected area of lung. Here's Aspergillus that's spread metastatically to the brain. You've got three lesions here in the brain from disseminated Aspergillus. And here's another brain with disseminated Aspergillus. Okay, some special tests for Aspergillus. The galactomannan test you can do on both blood and bronchoalveolar lavage fluid. None of the tests for Aspergillus is 100% sensitive or specific, and neither is the galactomannan test. But putting it together with your other information, it can be a useful additional piece of information. Also, the beta-D-glucan test can be used on blood, but it's even less specific than the galactomannan tests. A number of fungi make beta-D-glucan. Treatments for Aspergillus include voriconazole, the echinocandins, that's caspofuncan, anidulafungin, micafungin, lipid-associated amphotericin B, and the new drug posaconazole. This was a trial of voriconazole versus lipid-associated amphotericin B. And there were a little over 400 in both groups. Success, which was a combined endpoint, was 26% in the voriconazole group, 31% in the lipid-associated amphotericin group. And this was for febrile neutropenias. Some were Aspergillus, some don't know what they were. Breakthrough fungus infections, 2% in the voriconazole, 5% in the lipid-associated amphotericin group. Creatinine rise to over 1.5 times the baseline was more common in the amphotericin group, 19% versus 10%. Transient visual events, more common, of course, in the voriconazole group, 22% versus 1%. Okay, here's again in febrile neutropenia. This is voriconazole versus amphotericin B, the same study looking particularly at Aspergillus. These are breakthrough fungus infections, patients who didn't have Aspergillus to start with but got it later on. 4% in the voriconazole group, 4 individuals in the voriconazole group, 13 in the lipid-associated amphotericin group. So voriconazole was more effective there. Mucor, 2 in the voriconazole group, none in the lipid amphotericin group. Voriconazole is quite effective for Aspergillus, not effective at all for Mucor. This was another febrile neutropenia study of caspofungin, one of the kinocandins versus lipid-associated amphotericin B. Over 500 in both groups. Overall response, this again was a composite endpoint. 34% in both groups, so showed roughly comparable overall. But successful treatment of baseline fungal infection, these are patients who had a diagnosed fungal infection to start with, 52% in the caspofungin group, 26% in the lipid-associated amphotericin group. Successful treatment of baseline Aspergillus, 42% in the caspofungin group, 8% in the lipid amphotericin group, and that's 5 out of 12 the actual individuals in the caspofungin group versus 1 out of 12 in the lipid-associated amphotericin group. Survival beyond 7 days, roughly equivalent, 93% in the caspofungin group and 89% in the lipid-associated amphotericin group. So caspofungin came out roughly equivalent with lipid-associated amphotericin group in this febrile neutropenia study. Okay, this was voriconazole versus amphotericin B deoxycholate. This is the old amphotericin for Aspergillus, particularly for Aspergillus. Success at 12 weeks, 53% for voriconazole, 32% for amphotericin B deoxycholate. Survival at 12 weeks, 71% for voriconazole, 60% for amphotericin B deoxycholate. Renal impairment, just 1% for voriconazole, 10% for amphotericin B deoxycholate. So it looks like caspofungin roughly equivalent to amphotericin, and voriconazole somewhat better than amphotericin for febrile neutropenia and for Aspergillus in particular. Okay, this was a very recent study of voriconazole plus anidulafungin alone versus voriconazole alone for Aspergillus. Remember, voriconazole seemed better than amphotericin B. The echinocandins roughly equivalent to amphotericin B. But here's voriconazole plus an echinocandin, anidulafungin, between 130 and 140 in both groups. 6-week mortality, just 20% in the combined group, 28% in the voriconazole alone group. 12-week mortality, 29% in the combined group, 40% in the voriconazole alone group. These were all patients who had either acute myelogenous leukemia or else allogeneic stem cell transplants. These numbers did not reach statistical significance for the difference, but that is a substantial difference, and some people now are recommending the combination of voriconazole plus an echinocandin for Aspergillus starting treatment. Okay, echinocandins alone for Aspergillus. There have been some successes. There have been no head-to-head comparisons, as we saw, the echinocandins seemed roughly equivalent to amphotericin B, whereas voriconazole seemed better. No one's recommending echinocandins alone for Aspergillus at this time. Okay, questions about Aspergillus before we move on to Mucor. Okay, these are the genera of the Mucorales. There have been a lot of discussion about classification of these organisms. They were called Mucorales for a while. They were called zygomycetes for a while. And there's a specific genus called Mucor. But I'm just going to use unless I'm specify that we're talking about the specific genus, I'll use Mucor to mean all of these. The genera that are most important in causing infection include Rhizopus, Rhizomucor, Mucor, and Cunninghamella. Okay, now here's a Gamorrean methenamine silver stain of tissue with one of the Mucor. And you notice several things. They're much more delicate. They look like ribbons, much more delicate than the Aspergillus was. You don't see nearly as many septa, if you see any septa at all. They're more fragile organisms than Aspergillus, so you just sort of see bits and pieces of them. And the angle of the branching is much broader. It's either right angle or much broader than the acute angles that you saw with the Aspergillus. Now this is Mucor invading a blood vessel. Both Aspergillus and Mucor invade blood vessels. And you see here's the blood vessel wall, and it's filled with fungus. So of course blood isn't going to get through this vessel very well, and that's how you infarct tissue. Okay. We said you breathe it in through the nose, it can lodge there and cause infection there, particularly if you're predisposed to it. And here we can see it's spread out from the lining of the nose to the whole nose, and you can see black necrosis of the nose here out to the skin, and also evidence here that the orbit may be involved with this darkening of the skin around the eye and the swelling of the eyelids. Okay, here's a Mucor sinus infection. You see over on the left side, normal terminates. Over here on the right side, you can see that the terminates are swollen. The meatus is blocked. And here, and the sinuses, you've got retained material. And here is actual endoscopy looking in the two sides, normal on the left side, blocked with these masses of swollen tissue and fungus on the other side. Okay, here's a case of Mucor invading, probably got into the sinuses and then into the orbit, and over here coming from the maxillary sinus. Okay, here Mucor has gotten into the medial orbit with this black. Over here it got into the nose, and you've got black eschar on the bridge of the nose, and here on the palate, where you've got this black eschar on the anterior palate. So in somebody who comes in, with fever, and you see something like this, think Mucor and get the surgeons. You want to biopsy it and probably will need to debride. Okay, this is Mucor. Here's the maxillary sinus on the normal side, here on the side with the Mucor completely filled in. Here again in the sinus involvement with Mucor. This is the lung, widespread involvement with Mucor here. Here's an area, with a cavity and inflammation around it. Okay, and here's an area of what they call the reversed halo sign. Here's a Mucor with an area of of density here with an area of sort of ground glass in the center. The halo sign and the reversed halo sign are not specific for these infections, but they're certainly suggestive of them. So if you have the right clinical setting and see something like this, think especially Mucor, but also Aspergillus. Okay, and here's a Mucor with a cavity and inflammation around the cavity. Diabetic ketoacidosis is very important for Mucor, particularly rhinocerebral Mucor. Why diabetic ketoacidosis? A few reasons. First, neutrophil dysfunction. Neutrophils don't work that well in diabetic ketoacidosis. Remember, neutropenia is an important predisposition for Mucor. Neutrophil dysfunction also is. If you don't have effective neutrophils, either because of low number or poor function, that predisposes to Mucor. Also, there's increased unbound iron in the serum in diabetic ketoacidosis. Iron is especially important for growth of Mucor, and also Mucor have ketone reductase. Okay, treatments for Mucor, mainly lipid-associated amphotericin B, and the new azole posaconazole has activity, and it's mainly used as a step-down. Voriconazole has almost no activity against Mucor. Posaconazole has some, so usually start with lipid-associated amphotericin B, get the infection under control, and then once the patient is recuperating, no longer appears to have an active infection, you can finish up with posaconazole. Okay, amphotericin B for Mucor. This was patients with hematologic malignancies who were started on something else empirically that didn't have activity against Mucor. And this is the time from the first presenting symptoms to the start of any type of amphotericin B. And if it was, actually I've got these reversed, if it was more than 6 days, they had an 83% mortality. If it was less than 6 days, they had a 49% mortality. So delay in starting amphotericin B is quite important for Mucor. Amphotericin B is the treatment for acute mucormycosis, and you need to start it as soon as possible. Okay, surgery for Mucor, especially for rhinocerebral. You want to debride the dead tissue. The dead tissue is not going to come back to life. Now, which tissues are dead and which are still salvageable is an important surgical decision, which that's part of what they're trained to do. If you just leave the dead tissue there, it's full of Mucor, and they will invade the healthy tissues that are right next to the dead tissue and infarct the blood vessels there. Then you got more dead tissue. So you need to debride. Debridement is more crucial in rhinocerebral mucormycosis than for pulmonary. If you lose a little bit more lung, that's not too bad. It's bad, it's not too bad. But in the head, if you lose a little more of the head, that can be either disfiguring or disabling. So you want to get the surgeons early for rhinocerebral mucormycosis. Okay, summary recommendations for febrile neutropenia. You want to start antifungal treatment if still have fever after 4 to 7 days on antibacterial antibiotics. The people who are making the recommendations are not specifying what exact treatment to use, but I would think it would be either voriconazole, posaconazole, or one of the lipid-associated amphotericins. If you're at all thinking Mucor, use the lipid-associated amphotericin. And if the patient was getting an antifungal prophylaxis, change to a different class. A lot of these people are being put prophylactically on either voriconazole or posaconazole. So if one of those patients gets a neutropenic fever and doesn't respond to antibacterial, antibiotics should probably put that patient on lipid-associated amphotericin. How long do you continue it? Until the neutrophils recover up over 500. Okay, for Aspergillus, voriconazole plus an echinocandin or voriconazole alone, and the new echinocandin isuvaconazole has some activity against Aspergillus also. And for Mucor, lipid-associated amphotericin B, and you can step down to posaconazole when the patient no longer has active infection. Okay, any questions? Yes? Okay, usually at least 2 weeks and until all the symptoms are cleared and all signs of active infection are cleared. And if the patient was neutropenic, until they're over 500. Yes, anything else? Okay, thank you very much.